movement disorders because I really like the clinical exam. That's why a lot of us do it, right? You can tell a lot. I've certainly not unique, but I've definitely been at the mall and diagnosed Parkinson's disease. Most of us who've been movement disorders doctors for a while can do this kind of thing. But the truth of the matter is that I don't think subgrouping on the basis of clinical symptoms has gotten us very far in the field. Right. And it's probably because the clinical symptoms follow, essentially what areas of the brain are involved, right? Because the brain is so eloquent, right? It tells you which parts are kind of malfunctioning based on what a clinical manifestation is. But, what we have seen from a lot of, different neurodegenerative diseases and certainly movement disorders, some of them, is that the biology may not follow exactly the same way, right? Which brain regions and therefore the clinical symptomatology. And, the best example is probably not from Parkinson's disease, but from frontotemporal dementia, right? So those are people who essentially have involvement of the frontal lobes and the temporal lobes in their neurodegeneration, right? And so as a consequence, they have language problems, they have kind of behavior control problems, right? But if you look at their brains, right, it turns out some of them, accumulate a protein called TDP43, and some of them accumulate a protein called tau. Right. And it also turns out that, if you look at their genetics, it's sort of different genetics that lead to FTD with tau versus FTD with TDP. And this is just a long way to say that I think clinical subgrouping only goes so far. You need to have biological kind of subgrouping based on what are likely causal influences or kind of more direct readouts of the causal influences, And so that's kind of what's been motivating our lab's work for years on developing biomarkers, like based on biofluids of people, who have diseases. And actually Mind Initiative came out of our work with biomarkers because we started to realize, if we do develop good genetic or, biochemical biomarkers that allow us to predict certain kind of trajectories, who's going to decline more rapidly versus more slowly, who's going to develop impulsivity versus not, who's going to have Alzheimer's disease in their brain at the end of life or not. If we develop these kind of biomarkers, how are we going to enact them so that they would be helpful for our patients? It's only possible if we have already collected the genetic and biofluid from the patients to measure the biomarkers so that we can kind of close this loop. So that's kind of my thinking a lot about subgrouping. And, I might not be right. There are definitely really smart people who are trying to do clinical subgrouping, but I do think that's been going on for a long time, and I don't know how much it's really bought us in our field. I think it's going to be led by the therapies, right? Okay, so essentially, if, for example, you have, if you need to predict who cannot get a dopamine agonist, right? Then you just group according to risk of this thing, right? That's a different group from if you are trying to predict who will have beta amyloid plaques in their brain, right? Those people with beta amyloid plaques in their brain might be different with respect to how likely they are to become impulsive, whether they have a GBA carrier status or not. Those kinds of things may be different within that group. But if there's an if-then statement, right? So that if you know this, then you do that. The then statement defines the if, right? So that's what I mean by I think it's going to be therapy driven, should be.